Okay, sir. Thank you.
Good evening, everyone. I'm Dr. Manjula from Fever Foundation. It gives me immense pleasure to welcome you all to this evening scientific session organized by Fever Foundation. Fever Foundation is an independent and non-commercial foundation supporting educational and academic activities to address the unmet need in fever management. The foundation is committed to build, conceive, and sustain program and make it a scientific initiative which are aimed at providing evidence-based update to healthcare professionals. The vision of Fever Foundation is to strive towards imparting knowledge on the unmet needs and provide information on research, education, and therapy updates on Fever Foundation and fever management. We have several activities under Fever Foundation. Some of them are being annual Fever conference. We conduct regular conferences. More than 5 conferences have been done. It is attended by all physician, pediatrician, infectious disease specialist, intensivist, and all family physician. All people who are managing fever will come under one roof and discuss various aspects of fever management. We conduct fever CMEs throughout the year. We bring about books on fever management post every conference. We do support clinical and epidemiological research, and we have programs for postgraduate students in medicine and pediatrics. We have challenging case presentation competition for PGs, quiz competition for PGs, and poster presentation competition for postgraduates in medicine and pediatrics. Young Scholar Awards for young scientists, and we also involved in a lot of patient education, paramedical education, parent education, and public awareness activity. Now we are celebrating Fever Week starting from today, 24th May to 30th May, to commemorate the birth anniversary of Sir Daniel Gabriel Fahrenheit, the inventor of thermometer. On this occasion, Fever Foundation has organized several scientific programs. One is a national panel discussion. We have two such programs today and tomorrow. Today for pediatrician and tomorrow we have it for physician. And we are conducting CMEs across India. Approximately 1,000 programs are planned in this week. And also we have started patient education program for public awareness, patient education, parent awareness, and all the regional languages. We have doing it through FM radio. The entire week we will be conducting this program. It has already started today. I don't know, slides not moving. Yeah. So today we are here on the occasion of Fever Week for a very, very interesting topic on fever management, which is, I'm sure all of you will find it very useful in your day-to-day clinical practice, which is common errors in fever management in pediatrics. To conduct this program, we have a very eminent panel of experts who is helping us to conduct this activity. And also we are privileged to have chief guest with us, none other than Dr. G.V. Basavaraj sir, the National President of IAP. Sir is also Professor of Pediatrics and in charge of PSU at Indira Gandhi Institute of Child Health, Bangalore. And I thank him for accepting to be the chief guest for this scientific session. We have two eminent pediatricians as our moderators, Dr. S. Balasubramaniam sir, visiting consultant in pediatrics and former medical director, Kanchi Kamakoti Child Trust Hospital, Chennai, former professor of pediatric, SRMRC and Research Institute, Chennai, chairperson of IAP Infectious Disease Chapter 2022. And we have Dr. Jagdish Chennappa sir, co-moderating, consultant cluster heads of pediatric, Manipal Group of Hospital, past president, respiratory chapter, Indian Academy of Pediatric, 19 to 21, CEO of Metrain LLP, consultant, Child Central Hospital. So welcome to all of you. And before I hand it over I just quickly introduce our eminent panel who will be giving us the entire discussion on the very important topic of errors of fever management. We have Dr. Sara Sabud Madam, from Dean and Professor of Pediatric from Bharati Vidyapita Medical College and Hospital, Sangli, Maharashtra. Dr. Surendranath sir, Professor, Head and Department of Pediatric, Vijay Mary Hospital, Hyderabad. We have Dr. Abhay K. Shah sir from Chairman IAP ID Chapter, member of ACVIP, Senior Pediatrician and Consultant, Pediatric Infectious Disease from Ahmedabad. We have Dr. Rachna ma'am, Senior Consultant, Pediatrician, RAGP Children's Clinic, Professor of Pediatric and Medical Superintendent at PA Sangma International Medical College and Hospital. at Meghalaya. I welcome all the panelists and the faculty and the moderator and the chief guest to this program. Now, may I request our chief guest, Dr. G.V. Basaraj sir, to kindly give his opening remark. Over to you, sir, Basaraj sir.
Thank you so much, Dr. Manjula, madam, and all the respected dignitaries and the faculties of the today's program, led by Dr. Jagdish Chinnappa, Dr. Abhay Shah, Dr. SBS sir, Dr. Surendranath, Dr. Rachna Das Acharika, of course, Anand Keshavan, Anand Vasudev, and Sara Tanwade, madam, and all others who has been joined here, Jairaj, Girish, and I think Praveen and Kumar Swami is also there. Jairaj sir, welcome. So we are very happy. Fever Foundation over a years is doing an excellent job. Not only this year and subsequent years, they are doing a great job, especially which is related to the fever. Fever is one of the common problem as a pediatrician, as a general practitioner, we all come across. The month they have chosen it is in a very relevant, especially the May last week is in a very important thing which corresponds to the setting up of a monsoons in a southern part of India, especially Karnataka, Kerala, and Tamil Nadu. Of course, in northern part, it may take bit time, but here the season is going to start in the southwestern monsoon is going to set in. This is the time where we are going to come across with the many cases of a fever of a different etiology. So in that context, this awareness not only for the pediatrician to the general practitioners also it is a very relevant. And we all know majority of the time misuse of an antibiotic take place with the not all the fever is in a case of a request an antibiotic. The Indian Academy of Pediatrics, which has been already been forefront in this. Last month only, we have been created a lot of IAP ke baad, community ke saath is one of the program where Dr. Abhay Kantilal Shah was very instrumental in rolling out the program across the India to create awareness not only among the pediatrician and general practitioners, even among the common public also. So where the IAPS did a great job. Of course, we are this is supplementary to the what really the Indian Academy of Pediatrics, which has been done. Fever Foundation is also doing a great job on that. So this is where the lot of works needs to be done on this. And coming to the today's panel discussion, which has been led by none other than Dr. S.B.S. Balasubramaniam sir, along with Dr. Jagdish, Surendranath, Rajnadas Acharika, and Abhay Kantilal Shah, Sara Dhanwade madam. All are the pioneer in the infectious disease and also the fever. They have been involved in many years in the spreading of the knowledge in that. So it's going to be very useful. I'm sure all the practitioners and pediatricians who have been will be benefited out of it. Thank you, Dr. Krishna Kumar, for coordinating all the things. Thank you very much on this occasion. Best wishes to this program. Thank you very much.
Thank you very much, sir. Thank you very much.
Thank you.
Over to our moderator, Dr. SBS sir and Dr. Jagdish sir for the session. Over to you, sir.
Thank you very much, madam. And we can straight away go into the auditorium, and we can start the proceedings with your permission. Dr. Balasubramaniam, shall we start?
Yeah. Please start. Please go ahead. Okay. Go ahead.
Okay. So we can get to the webcast view. Very good. Excellent. So, Dr. Balasubramaniam, we can start off with the introduction, please.
Thank you. Thank you very much. Thank you, Manjula and her team from the micro. And thank you, Professor Basaraj, for those very gracious and nice comments. Let me thank Micro for giving this opportunity for me to take part along with the none other than Dr. Jagdish Chinnappa to discuss common errors in fever management in pediatrics. Before we start, what we have planned is like this. Actually, Jagdish and me, we just discussed only for 5 minutes, and Jagdish immediately sent a few areas where we should discuss. And what I did, there was nothing which I could do to improve upon it. We circulated to the experts, and then from every point which Jagdish wanted to discuss, I created a case scenario and ended up having, I think, 15 case scenarios where they're all very common issues we see in our day-to-day practice with reference to fever management. And including me, all of us do make some mistakes. And we are trying to create awareness about the common errors in management with this program. Can I have the first slide, Krishna? Yeah, we have, no, please hold we have, of course, Jagdish doesn't require any introduction. He is a veteran, not only in pediatrics, but also in pediatric ENT and pulmonology. And we have Dr. Abhay Shah from Gujarat, the former chairperson of the infectious disease chapter, an extremely learned person, and he practices rational pediatrics and is an expert in infectious diseases. We have from the East, Dr. Rashna Das Hazarika, who's well known for her expertise in infectious diseases and pediatrics. And Dr. Sara Subodh is from Goa, is from the West again. She's professor of pediatrics. She was involved not only in undergraduate teaching programs, but also in postgraduate teaching programs 2 years back for the DEAP. Her knowledge is fantastic. We have Dr. Surendranath from Hyderabad, who's an expert in vaccinology, infectious diseases, and in general pediatrics. And we look forward to having a wonderful session with great inputs from our panelists. Can I have the next slide before I hand over to Dr. Jagdish? You must be wondering, please put the entire slide on, Krishna. Animated, yeah, unfortunately, right. We all know the commonest symptom for which pediatricians see children, other than perhaps vaccination, is a visit for a vaccination. And the commonest reason why a pediatrician sees a child is for fever. Unfortunately, it is not only a common symptom, it is also the most commonly mistreated, inappropriately treated symptom. Fever, in most situations, is the symptom of something which is very trivial. In fact, studies have shown only 1% of all fevers, 1%. There's a reference for it, Western reference, of course. 1% of all fevers in children, acute fevers in children, only is due to a serious bacterial infection, only 1% across the ages, from newborn to 18 years. Only 1% is due to a serious problem. But fever can range between a trivial symptom to a life-threatening one. It can be an emergency like, dengue shock syndrome, meningococcemia with hemorrhage, meningitis, etc., etc. What we are planning to do is to discuss some case scenarios with our experts where there will be dilemmas for all of us in the correct approach to management. And we will elicit answers from these 4 experts, and we will try to find solutions to the dilemmas we all face. With this, I request Dr. Jagdish to start the first case and proceed forward. Thank you very much.
Thank you, Dr. SBS. As usual, he is a master at conducting such programs, and it's fortunate that I could partner with him for this particular session. just a little bit of how we are going to go about this whole session. We have basically 15 case scenarios. So what we will do is I will do the first 4 case scenarios with the 4 participants, and then Dr. Balasubramaniam will take over from 5th case onwards, so that we can rotate it alternately. We will start randomly. None of these cases have been distributed or earmarked for any of the panelists. So I will just choose at random one of the panelists to answer it. So can we go to the next slide, please? Let's start off with case scenario 1. The mother of an infant, 8-month-old, feels that the child has fever and checks with a thermometer like this. It's a digital non-contact infrared thermometer, and comes back and tells you that the temperature is 100 degrees Fahrenheit. How reliable is this reading? Do we need to recheck it at all? Can I start with Dr. Sara? Dr. Sara, what do you think about this?
Yeah, this is one of the newer methods of ever since COVID. I think we are more familiar with this non-contact infrared thermometer. But of course, the downside of it is that it has got accuracy is less as compared to the digital thermometers that we use. So we definitely need to, because the technique may not be correct. Also, it can be hampered if the patient is just gone out, exposed to sun or exposed to cold. So there are other factors which interfere with this temperature. So definitely it needs to be checked with an axillary temperature.
So, Dr. Sara, do you think that an axillary thermometer is the gold standard for most of our patients for checking temperature?
Yeah, the gold standard, when we say gold is gold, rectal has always been considered as a gold standard, but it is been kind of done away with it because of many reasons, like the difficulty in using, the chances of infection, the complications. So next to it, now almost axillary is considered as the most commonly used and accurate thermometer. And the other one would be in children more than 6 months, you can always use the tympanic temperature, which again gives you an idea about the core temperature.
Thank you, Dr. Sara. Would you also just give a few tips to our viewers on the correct method of taking an axillary temperature?
Yeah. We no more use mercury thermometer. It's all the digital thermometer. So we need to have the bulb of the thermometer inserted into the axilla, and the thermometer will be parallel to the body. And the arm has to be closed and closely adducted and kept, and till the beep comes, of course, in the digital on the digital thermometer. So the placement of the thermometer is important, and also you should fix the arm close to the body.
Okay. Any of the other panelists wants to add any point before I move to the next?
Dr. Jagdish.
Yes, sir.
Dr. Jagdish, if you unfortunately, if you go to the textbooks and see the definition of fever, they mention rectal thermometer as the gold standard, rectal temperature as the gold standard. And that too, after the advent of COVID, we have stopped oral as well as rectal measurement. But even in newborn nurseries today, we don't measure the rectal temperature anymore. I want to ask these experienced panelists, I mean, there are some parents, who may have their own thermometer for a particular child. For an older child, they may measure it in the mouth, or they may measure it in the armpit, and they may come and ask you, armpit, should I add one or not? Can any of the experts take the question? Because that is a common confusion, no? Parents, when they come with the reading, they always ask, sir, should I take it as 100 if it is recorded as recorded in the axilla, or should I add 1+?
No. So can I answer this, sir?
Yeah, please.
Please.
Yeah. So usually it is said that the oral temperature is 0.8 to 1 degree higher, and the axillary temperature is 0.8 to 1.5 degree little lower. But I think there is no need to deduct or to add something from the water value that we have got as per the record. I think that once you have got a basic figure of temperature 98.4, maybe 100, 101, then that is a basic. And after that, we'll follow the child, how the child is responding in terms of a response to paracetamol, other activity, and oral. So there is no need to subtract or there is no need to add, depending upon the site of the measurement of the temperature.
Very good point, Dr. Abhay. I think the very important point is that, again, like growth, we monitor growth in children. Like that, we need to know the trend of fever. We need to monitor the temperature at the same site and see how it is progressing, rather than taking a single reading as a big issue. So I think that's a very important point you brought out, Dr. Abhay. Now I'll come back to you only.
Sir, one more thing, sir. The duration of the thermometer to be kept in the axilla is also very important. Nowadays we have the beep. Nowadays we have the beep, but ideally at least
3 to 4 minutes.
the temperature should be recorded.
Thank you, Dr. Surendra. Thank you for that.
Gold standard is 5 minutes. Gold
Yeah,
standard
5 minutes. It's 5 minutes. It's 5 minutes.
Okay, coming to Dr. Abhay. Dr. Abhay, now there's a grandmother who brings a baby and says baby is warm and having fever. She has not checked the thermometer. How reliable or unreliable is this measurement?
Now, this is, I think, this is absolutely an unreliable method. Only thing that if the fever is very high, you can perceive that, of course, the child has got more than 100 degrees. Then it will say idea that yes, something is wrong with the child and it is the time to intervene. You should look at the discomfort of the child, not only the warmth or the coldness of the child, but the touching is, I think, the worst and should never be practiced. Ask them to unbundle the child, expose the child for 4 or 5 minutes. And if the child is uncomfortable or if you feel feverish from the skin tactile contact, then you put the thermometer, and that is auxiliary is by and large the best method for the practical purpose. And if the fever is more than 100 degrees, I think, and if the child is uncomfortable, I will do the paracetamol. So touching is a crude method and will not give any idea. Only thing that it gives, yes, the child may be febrile, but you have to confirm it with the help of the thermometer.
True, very true. So, but I think we should always respect grandmothers, no?
Yeah.
I mean, if grandmothers say that there is a child has got temperature, then I think we should at least check the temperature with an expert.
So, also, Dr. Jagdish, I would add that if you look at the American Pediatric Guideline of 2021, they would clearly mention that if the parent feels that the child is febrile, we should consider that the child has got the fever. Yeah, there is a definite sentence they have mentioned it. Yeah.
So I think much before American Academy of Pediatrics, much of our cultural practices were far ahead of them. Yeah. And grandmothers were very apt at picking up fever in children.
Exactly.
So let's move to the next one.
Jagdish, one comment. One comment,
yes,
Jagdish.
Yes, sir.
Actually, there is a very interesting publication which came about 15 years back. They actually assessed young infants and young children who were perceived to have fever by the relatives, and at home, no measurements. This is about 15-20 years back. At home, no temperature was measured, and they did an emergency assessment of these children. What they came out was that if the relatives, when I say relatives, the term includes parents or any caregiver. If they feel child is warm and having fever, the chances of the child having fever, true fever, are nearly 75%. So they are more likely to be right than wrong. However, in India, the problem is that, for example, in Ramagundam, if you have a child, today, with the environmental temperature of 47, every mother will feel child is febrile. Second, young toddlers who have iron deficiency anemia, they may have vasodilatation, high cardiac output, and they may be perceived to have fever. Instead of perceiving it as warmth, many parents will mistake the warmth due to vasodilatation as fever. So an infant in the Indian setting brought for being warm might also be having iron deficiency anemia. This is beyond fever. Thank you, Jagdish.
Thank you, sir. Thank you very much. Now we'll go to Dr. Rachna. Dr. Rachna, you have 2 infants. Both are around 15 months or 14 months of age, with fever of a short duration, just about 6 hours, but measured temperature is 102 degrees Fahrenheit. Both have been given paracetamol 15 milligram per kilogram an hour ago. In the one infant you have who is absolutely afebrile, the other one has still 102 degrees persisting. So is the second infant more serious than the first infant? What is your inference and what should you do next?
Thank you, Dr. Jagdish. Very interesting scenario, I must say. So if I look at these two infants, I think the first infant really has fever in this weather, which has responded to paracetamol. But if the second infant probably has hyperthermia because of the heat, and that would not respond to paracetamol. That would be my first inference in the setting of today's high temperature all across the country. So I would observe the child and try to do some warm tepid sponging and see if the temperature goes down. Secondly, the dose. We have inferred that they have been given 15 milligram per kg, but has the dose really been given to the child? Has the child vomited? So I think these we'll have to check, and then only we'll know whether the second infant is more serious than the first one.
So any other comments from the others?
Are they from same family, sir? Are they from same family or different families?
No. They are from neighboring family.
The problem is sometimes what happens is if it is a suspension, you have to mix it properly. Otherwise, what happens is supernatant they give the paracetamol content may not be appropriate like 15 mg per kg body weight. That is one thing. Any fever which is not responding to the paracetamol, we have to think of some CNS cause. Because most of the time CNS causes of the fever, they persist even after giving the paracetamol, apart from the environmental fevers.
Abhay wants to come up with something now.
Yeah, so when usually the 50 milligram dose is a good dose. So if the bottle has been shaken well and if there is no supernatant fluid has been given, the dose has been collected, digested and not vomited, I think the child should respond within next 2 hours. Now it is only 1 hour, say, so if the child is not that uncomfortable, I would not worry. But second time, what Dr. Rasna has made that if there is a heat stroke, if there is a heat fever, then probably the paracetamol is not going to work because the mechanism of fever is going to definitely different where the hypothalamic set point is not involved. And third one, that you will look at the further steps. If the fever is not in paracetamol, I think it is less likely to be viral by and large. And I would really worry. Of course, at 2 hours or 3 hours, with a 1 dose of paracetamol, I do not conclude anything. But yes, this is the child who has not responded to paracetamol and something might be different going on. That is the history and further interferable period, everything will tell us.
So Dr. Sara, you want to come in now? I think there is all the others.
Yeah, I think I would agree with Dr. Abhay. I would see whether the child is, how is the child? Is he playful, active? That's very important. And obviously it is a little bit worrisome that with paracetamol, the child has not responded if the dose has really been. So probably you need to look into other causes, and maybe I would think of using an alternative medicine at this point, because having waited for 1 hour and the patient is still not responding. I don't know what the other panelists would think of that.
No, I would go for the tepid sponging, especially in the month of this summer, rather than
One more thing.
I don't know. I don't know. We have waited 1 hour, so whether we can use alternative medicine at this point. I won't switch or alternate, but I want to see, because he has not responded to paracetamol, but it doesn't mean that he will not respond to ibuprofen.
Yeah. So I think we have got a lot of ideas here.
Yeah,
and I think the first idea is that this could be environmental heat. This may not be true fever. It may be hyperthermia, and therefore we wait. The second suggestion is that we should give ibuprofen. The third suggestion is to wait for some more time and check whether the medication has been given properly or not. So there are a number of approaches, all of which may be right. So I think it depends on the individual situation. And I think we need to follow this child up and see whether there's... Just 1 second, Balasubramanian will come to you. We'll come to you. Expert opinion always last. So I think we've got a lot of different churning happening here. So I think the rational approach, I suppose, is probably to wait and watch for another hour and see in a cool temperature and see whether this child responds.
I just wanted to add one more thing.
Yes.
The hydration of the child.
Yeah.
Yes, that's important. Yeah.
Yeah, very good. So yes, doctor. Now we come to the expert, Dr. Balasubramaniam.
No, I'm not an expert.
Amitabh Bachchan has to give his final opinion as to what's going on.
No. My answer is, my inference is zero. I don't have any inference with this data that is given. It doesn't make any difference at all. There is no difference between the child with the data given. Let me complete my argument. With the data given here, the child who has fever and child who doesn't have fever at 1 hour, to me, it doesn't make any difference. But on the other hand, the first thing I will do at 1 hour is not to worry about, in fact, I wouldn't even bother to take the temperature reading. I would look at the ABC of the child carefully, and I will look at the overall activity of the child. In fact, I have seen this happening. The child with 102 will be playing. The child without fever may be lethargic. In fact, there is again a good reference for this, where they did a study in the emergency room. They compared children who responded very well to antipyretic versus children who did not respond to antipyretics over the next 4 hours after an initial dose of an antipyretic. And they looked at the etiology of fever. There was no difference in the incidence of serious bacterial infection in those who responded promptly versus those who did not respond to antipyretic. So the moral of the story is, just because the fever comes down dramatically with 1 dose of paracetamol, we are not excluding serious bacterial infection. Just because fever doesn't come down, we should not infer it is 100% bacterial. We should look at the ABC. Last is, the number matters very little. Number matters very little, particularly in 14 months of age. So newborn, yes, anything even 100, I would start worrying. Look at the age, 14 months of age. I wouldn't worry about the number. I would worry about the activity of the child. Prompt antipyretic response to any paracetamol or ibuprofen is not enough to distinguish serious bacterial infection versus trivial viral infection. That's the moral of the story.
Thank you. Thank you, Dr. Balasubramaniam. Now we come to the last of the first set, and we'll come to Dr. Surendranath. And that is a newborn born at Ramagundam. Next slide, please. Birth weight is 3 kilos. It's May month, day 3. The digital temperature of the axilla is 101 degrees Fahrenheit. Is this dehydration fever, or is this sepsis? Is this an emergency? What should you do next? Should you admit the child?
Yes, sir. The most of the times in environmental temperature is very high during the summer months. So most of the newborns who are not able to maintain the temperature because of the high environmental temperature, their temperature goes up, sir. Because it is a day 3 child who is not having enough milk also, because few colostrum drops will be there during the first 2 days. So inadequate intake of the fluids also one of the reason when there is high ambient temperature is there. So we have to check the weight loss, whether there is any weight loss is there or not, because it is the 3rd day. If it is more than 10% weight loss, okay, there may be some dehydration associated with the newborn, which can happen in a very high ambient temperature. So if there is no predisposing conditions for early onset of sepsis, like prolonged rupture of the membranes or maternal fever, some such things are there. Maybe most of the times, in my experience, it is because of the high environmental temperature. The child on the 3rd day may have a high grade fever, especially it happens in the month of May, where very high temperature can give rise to the fever in the newborn. So if the child is active, feeding well, asking for the feed, without any signs of sepsis, I would better observe this child, keep it to mother, keep it in such a room where the temperature is less than compared to the ambient temperature of the outside.
So I think we can wait because third day, if an active child is there, if any dullness is there, definitely we will investigate for any infection and then treat accordingly. But most of these scenarios do happen regularly at our areas. So in my experience, most of the time they do reduce the temperature after keeping them in a proper environment with the adequate feeds. That's what we have to do, sir.
Any other points of view? Anybody else has another point of view? Dr. Abhay wants something to say something. Dr.
Yeah,
Rashna and Dr. Sara. All three want to say something. So I will start with Dr. Abhay.
Yeah, so it seems to be a dehydration fever, but I think third day is little early to me, number one. Second, even if the febrile child neonate is whatsoever is a good looking, I will treat as a dehydration fever. May not be in a hurry to start antibiotic, but I'm really in a hurry to start the septic screen.
Thank you.
And of
Yes,
course,
sir.
electrolytes, urea creatinine, but
So
I will at least
when you say septic screen, what are the things that you would do, Dr. Abhay?
at a first track, because the chances of here dehydration fever are more, I would just go for the CBC, CRP, urine, band cell count, IT ratio. And if sepsis screen is positive, I will go for the blood culture and CSF if I'm going to start the antibiotic. So I will to a limited, I will not involve at this stage blood culture and this CSF, but I think we'll go for the CBC and CRP. And of course, urine examination. Yeah.
Yeah. Dr. Rashna, you have any difference of opinion?
Yeah. I think day 3, May month, dehydration fever is most likely. After we have exposed the baby and done a little warm, tepid sponging, then you have asked a question, is this an emergency or not? For me, it's an emergency in the sense I would like to look at the sodium, because many of these patients do land up with hypernatremia. And as far as the sepsis screen is concerned, I would not do it immediately because this child is already dehydrated because of the fever. So I would like to rehydrate the child, and then if required, if the fever is persisting, then do the sepsis screen. Because if you do a sepsis screen at this point of time, then you're anyway, this dehydration is there, the counts are anyway going to come high. So I think I would just hold on, try to correct the dehydration. And then if it still persists, then I will go to what Dr. Abhay sir has suggested.
Dr. Sara, your opinion, please.
Yeah. I also think that this is an emergency. And secondly, how much you can depend on the clinical status in a newborn. Because regardless of the clinical condition, a fever in a newborn is a serious symptom. So we know the setting is like day 3, 4, then the milk secretion is less, and we are most probably looking at dehydration fever. But personally, if you ask me, I would definitely like to rule out infection. And dehydration fever becomes a diagnosis of exclusion for me. I wouldn't just put all my bet on dehydration fever because this is a newborn baby. And I would at least do that, because activity, this dehydration fever baby is also going to be irritable or maybe, sanguinized, lethargic. So it is not going to be a well-looking child. And in any case, newborn, we should never depend on the clinical appearance of the baby. And fever is a serious, sinister symptom, and we need to give due care. And also, we should look for jaundice, which that point did not come up. I would look at the jaundice because usually these babies have deepening of jaundice, and of course, sodium can go wrong and other things. So I would be a little cautious, and I would rather do a screen and then before putting my bet on full dehydration fever.
Thank you. Now we will request the third umpire to give his opinion.
Okay, Jagdish, before I decide to do anything for this baby, I will again take history properly. What history should I get? The same story happens in an MLA's grandchild with the baby being kept in an AC room with a temperature inside 26 degrees, outside temperature 47. Baby not being wrapped very well, kept with normal clothing. And the baby also has some difficulties in feeding, in the sense some lactation problem. Temperature like this, I will react immediately. So that is, again, history is very important. On the other hand, if it comes from a lower socioeconomic status, no AC at home, baby being wrapped up in a sweater in the month of May, very thirsty, very hungry baby, I might think of dehydration fever. But in any case, this baby, I would not send the baby home. I would definitely evaluate. When I say evaluate, it may include just putting the baby in an AC room, checking the breastfeeding, checking the urine status even for 6 hours, and then deciding on septic workup. Or, as I said, the MLA's grandchild from the AC room, straight away I will do a septic workup and proceed. So what I am trying to say is that just because the infant is in a place where the environmental temperature is high, we cannot label any fever, even if the neonate is well clinically, as dehydration fever. It is a diagnosis of exclusion. It's not one cannot make straight away a confident diagnosis. You have to be extremely careful in such a situation. 0 to 28 days, any temperature like this, one has to be extremely careful. And here, what I would like to stress is that blood counts are not very, very useful if the temperature is for less than 24 hours. And of course, CRP, and if somebody can afford, today in 2024, I would do a procalcitonin. In fact, in April 2024, an article had appeared in Pediatrics where they have shown that procalcitonin is much superior to CRP and other clinical rules in picking up bacterial sepsis below 3 months of age. Of course, it's expensive, it's not widely available, but in a difficult situation, I would add that also in my diagnostic armamentarium.
Okay, I have a question for you, Dr. Balasubramaniam, not to the panelists, but this is a little out of syllabus, but I'm asking you the question. Would you give antibiotics to the MLA's grandson in the who is staying in his air-conditioned room, or would you give it to the lower middle class who is faced with the environmental stress of temperature? Would you give cephaloxime with ampicillin to both of them?
Irrespective of whether it is MLA's child or a poor man's child, if I admit and decide to do a septic screen, if clinically the baby is ill, I won't even go by septic screen. I will start intravenous antibiotic. If clinically well, if septic screen is negative, I might withhold antibiotic. Okay. On the other hand, if septic screen is positive, I'll go ahead, do a lumbar puncture, start antibiotic. And definitely today, I don't use cefotaxime or ampicillin in the newborn period. We go for either piperacillin, tazobactam with or without aminoglycoside or meropenem.
Thank you.
I think it is too early to investigate, sir. 3 days baby. I think we can give some time, at least 6 hours, see the response of the baby. That's what normally we do. 6 hours we observe the baby. If there is any signs of sepsis, definitely we can do the investigation and start the antibiotic.
Agreed.
Okay.
Agreed. I never said I will start antibiotic. I said I will observe, reassess, and do a septic screen and then decide on antibiotic. If the baby is ill, I wouldn't wait even for the septic screen. I'll straight away do the test and do a lumbar puncture and start antibiotic. If the baby is well, yeah, I will do a septic screen, then decide on antibiotic. I agree with you. First thing I will do is to assess, but I won't send the baby home. That's what I said. I don't have the guts to send this baby home.
I think
definitely
Dr. Bala, Dr. Surendranath is talking about a institutionalized baby. The baby is already in the hospital or nursing home. So I think we'll leave that for the time being. The other issue is regarding the occurrence of fever after hepatitis B vaccine. Now, hepatitis B is given routinely to babies, and there has been shown that these babies have a higher incidence of temperature rise. So, anybody wants to comment on that?
Sir, we give routinely the birth dose. In fact, first day within 24 hours, we try to give the birth dose. But most of the times, in my experience, I have not seen any fever for the hepatitis B, or for that matter, BCG, oral polio. But the second, third day, 100 degrees, 90 degrees raise of temperature is normally seen in those babies who do not feed, frequently. Mother is having less milk during the first 2 days. So most of the times, parents do complain about the fever. Automatically, they attribute it to the vaccination. Next day, when you go, even 99 fever also they attribute it to the vaccination. But I don't think a hepatitis B will not cause any raise of the temperature.
No, I think there is a paper which has come out from, if you look at one of the papers that came out from Israel in early days, they showed that when they followed up children who had given the hepatitis B versus those who did not take the hepatitis B, there was a rise in temperature which is much more in those who had taken the hepatitis B vaccine. So anyway, we'll go to the next set. Dr. SBS, you can take over now.
Yeah.
Just
Krishna,
before we go, I think that hepatitis B vaccine issue probably was related to the preservative and not to the vaccine per se, if it was a paper earlier on. Because sometimes alum-based, I think, vaccines, they do cause reactions to the alum and not to the vaccine component. I don't know, I'm just having that thought. Because even I have not seen, like Dr. Surinder
Yeah.
said, any patient getting till now.
Usually, we don't get that fever in our child after birth dose. Yeah.
I think we can do a study.
Yeah.
Krishna, can I have the next slide? Yeah. 12 days neonate. Birth weight was 2.3 kg. Borderline preterm, cesarean section. Was in a small nursing home from day 3 to 6 for phototherapy for hyperbilirubinemia. At home from day 6, fever 102 on 12th day. And the family practitioner advises over phone, gives cefixime drops 0.5 ml BD. And they want you to advise. Dr. Surendranath, please.
Yes, sir. This baby is now, I think, 12 days old, who was in the NICU. Maybe phototherapy must have been kept in NICU for 3 to 6 days. And after going home, child developed a fever. This child is definitely, we have to suspect some infection, either from the NICU. So it is a late onset sepsis as such. So we have to investigate this child. Definitely this child requires admission, fever 1 or 2 for 12 days baby. I will not take it lightly. Definitely I will admit this child. And GP giving cefixime drops is useless and unwarranted. And oral antibiotics are not useful in children who are having the fever, definitely. So we have to rule out any severe bacterial infection like septicemia or meningitis in this child. Admit and investigate properly with CRP, CBP. And if there is no convulsions, we can do the LP after getting the blood culture report. And we have to admit this baby in NICU and start the antibiotic, and at the same time send the investigations for the sepsis screen. That's what I will do, sir. This baby.
Dr.
Because
Abhay,
Yeah.
Dr. Abhay, will you give paracetamol drops to this child, baby, to this newborn?
Yes, we can give it. If it is more than 100 degree, I think if child is uncomfortable, restless, I will give it. But just not because the temperature is there. But if the child is restless, I will definitely give it. But second thing, I will not wait for the report of blood culture. I will straightway go for the CSF upfront and will start the antibiotic with a good CNS penetrance. So I will give paracetamol. I will be little harsh and fast in giving the antibiotic, and that is a good CSF penetration. And we'll say that this is a potential case for the ESBL because the child has been exposed to a nursery organism. Even in community also ESBL is very high. So accordingly, I will apply my antibiotic therapy. So there is no role of cefixime oral. There is no role of even parenteral ceftriaxone, and I'll go little higher one antibiotic.
Rashna, do you give paracetamol drops to newborn like this, or you don't give?
Only if there is discomfort. I don't remember prescribing, but if the baby is in a lot of discomfort, maybe
Yeah, then only.
excessive crying, irritability, unconsolable. But then I agree with all the other panelists that this baby will require an extensive investigation, rather aggressive management from the time we have detected, because this is likely a late onset neonatal sepsis.
Current recommendations suggest that it's better not to use paracetamol, more so if the baby is preterm. It's not recommended. That is one. Second thing is, in case you decide to admit the baby, what is a septic screen that you will do? Dr. Surendranath or Dr. Abhay, anybody can take it.
So I will go for the CBCs, TRP. If the resources are available, I will straightway go for the ProCal as well. I will do blood culture. I will do urine routine and urine culture, and we'll start. And CSF, again, we'll send for the smear and culture. These are the basic things I would do. And if the respiratory symptoms are there, I might go for the X-ray test.
Okay. Yes. Jagdish, your comments?
No, I think everything has been covered. The only other thing which I would also look at is that this child is borderline preterm with a significant phototherapy having been given. So another thing which could happen is excessive weight loss in this child. So I think hydration is a very important part of this, and I think BU and creatinine also should be done upfront, along with all the other things which Dr. Abhay has mentioned.
Okay.
So will anybody think of dehydration fever here?
Yeah, dehydration as a contributor to fever.
This
not
also had phototherapy. You know that time the feeding. Maybe anyway, Bala sir, very sketchy history you have given us. You have not told us how the baby.
This is phototherapy from day. Sarah, phototherapy from day 3 to 6 only. Now it is 12 days old. There is no question of phototherapy causing fever.
No. I'm not saying that. I'm not sure whether the breastfeeding was established at the time of discharge. This was a late preterm, I suppose. And we don't know whether the baby's breastfeeding has been established, the adequacy of the breastfeeding. We have not got any news.
But Dr. Sarah, dehydration fever does not occur in a preterm who is 12 days old. This is not the setting of dehydration fever. That's the lie. I don't think, unlike the previous one, which is 3 days old, term infant.
Agreed. Late onset sepsis would be the first choice, but suppose the sepsis screen had come negative in this baby.
Then I will repeat it. Start the antibiotic, wait for the blood culture.
Whatever it is, if there is severe weight loss is there, okay, we can suspect, but weight loss is one criteria you have to take for a dehydration fever causing for the second week baby. There should be weight loss, definitely.
No, I don't think in this infant who is preterm, who is born with a weight of 2.3, who has been in a nursing home for up to 6 days, now having fever on day 12, the first thing I will think of is sepsis.
Yes, sir. That is correct.
Everything points towards only sepsis in this baby. I wouldn't give paracetamol. I wouldn't give cefixime drops. I would admit this baby, aggressively investigate, and even if the septic screen is negative, I will give antibiotics to this child. You must also remember, all the septic screens, including procalcitonin, don't have 100% sensitivity and specificity. In fact, the latest literature says that procalcitonin has got more sensitivity than specificity. So even the best of your septic screen test will not exclude sepsis 100%. So you have to use your clinical judgment, wait for the blood and CSF culture before you decide to say this is not fever due to sepsis. Of course, if you look at literature, even in the neonatal period, 0 to 28 days, the commonest cause of fever is not bacterial, it is viral.
Yes.
Viral, even in neonates. But that doesn't mean I would ignore fever in a preterm infant.
Dr. Balasubramaniam, I don't think that any of the panelists or any of us think of anything else other than sepsis here. But you also have to keep in mind, that this child has had phototherapy, has been in the ICU, is preterm, probably has not been fed very well. We do not know about weight loss. So adequate hydration is extremely important, because you have to look at the kidney function. You have to look at the glucose. It's not just looking at only the sepsis. That was the point which I made, not that there is a possibility of dehydration.
Agreed. Yeah. Let us move to the next case. Case 6, 1-year-old male infant, fever for 1 day, maximum temperature recorded in the armpit 103. Absolutely no clues on examination. And the pediatrician, primary pediatrician, asked for a complete blood count CRP, and he gets a report from the lab. Total count 14,000, polymorph 80, and platelets 2 lakhs, CRP 24 milligram per liter, and he starts oral amoxiclav. Dr. Sara, your comments on this, and how will you proceed with this child?
Okay. This child has fever. The onset looks like it started with high-grade fever, but it's just 1 day fever, and there is no clues on examination, which means that probably ear is normal, throat is normal, and no obvious focus for infection. So this falls into one of fever without focus. And it is on the first day of fever. It doesn't call for, first of all, no investigation is required on day 1. Also, there is no information is given about the activity, whether the child, how is the child behaving, how is the child feeding. These informations are not given here. If the child is not sick looking, there is no need to do any investigations on day 1. And day 1 investigation doesn't tell you anything. Fever which starts with high grade, most probably it could be viral. It can also be bacterial with the point of entry, infection at the point of entry. Obviously, there is no clue. But the 14,000 count, polymorph, all fevers, even viral fever, have polymorph or nuclear predominance in the first day. And the CRP 24 doesn't tell me whether it is viral or bacterial. And I will not start amoxicillin because it's just 1 day fever. And the child, if the child is well looking. Of course, if the child is sick looking, I will not look at it. Any child who is sick looking, of course, will need we will intervene differently.
Dr. Surendranath.
Yes, sir. As madam told, 1 day fever, I will not do anything. I'll just give him paracetamol, ask them for the review after 48 hours. This child will not require any investigations. Just observe him. How is the fever? Give paracetamol, wait for 48 hours, ask him to come for the reviews. There is no need to start antibiotic.
Abhay?
I think it all depends what is the epidemiology, what is going around. If the same child comes to me in the monsoon, probably I will go for the CBS NSC. But for a given, without such an history, without such outbreak, if the child is vaccinated well, if the child is playing well, is interacting with you, taking orally well, I think 103 fever on day 1, no injection is required. There are only few indications where the first day injection is required. But one, when the fever is there, irrespective of the height of fever, if the child is sick looking, if the child is newborn or less than 3 months of the child, if some outbreak situation is going on, and if some immunocompromised child is there, this 4 are situation where the first day investigation are required, other is not required. And this total count 14,000, it's a stress reaction, not a polymorphic viral infection. Again, I will avoid it. So these are not required, and only paracetamol, close observation, and explaining the red flag sign when to come back is very, very important.
So Dr. Surendranath?
Only thing I think we add for urine examination. In this case, I will go for urine examination.
Okay.
Yeah.
Sir, I think background, a little bit of history would be required. Is the child immunocompromised, like Dr. Abhay has said? Is the child on any steroids, like a nephrotic syndrome? So those kind of, I think, history taking is important. The second is we should follow the traffic light system for identifying the serious illnesses, which is given by very nicely by the NICE guidelines. And if we follow that, then we can find out with what risk the child is. So apparently here it looks like a viral infection on day 1. And I would not even do any investigation, forget starting amoxiclav. I will just observe the child. If the child is playful in between the fever episodes, that's a nice clue to say that probably this is not a very serious illness, probably just a viral infection.
Okay, the moderator begs to differ from all the 4 panelists for a change. In this infant, 1-year-old,
urine.
with a temperature of 103, I will definitely do a urine routine. That's what
I told sir urine examination.
No. All of you said no investigations.
No,
last
only urine examination. Okay.
No. No, but first, no, agreed. Abhay, your knowledge, there is no question at all.
No, sir.
But I have to drive home this point to the audience. I don't think they should get the message that day one fever in a 1-year-old male infant, you don't have to do anything. You have to do a urine exam. In fact, I'm quoting the guidelines in the NICE guidelines also, or in the AAP guidelines. Well, they put a few criteria. One is, in fact, Dr. Rashna asked about history. I think I will ask circumcision history in this child. If it's a Muslim child who has been circumcised, then perhaps I might not do a urine routine. Okay, uncircumcised male, okay, fever without focus, 7% of all children between 3 months to 36 months, 7% have UTI. The other important point, we all know, pediatricians, we all know that UTI below 3 years may not produce symptoms referable to the urinary tract. There may not be dysuria, there may not be foul smelling urine, there may not be abdominal pain, there may not be urgency, increased frequency, etc. Only fever may be the symptom. So urine routine is the only investigation that is required in this child, and complete blood counts on day one in a 1-year-old child is a waste of money. If there is fever without focus, unless you have splenomegaly, unless you have clinical clues to suspect something sinister like malignancy, I think 1 day fever, blood counts 14,000, 13,000, 12,000, 4,000, it doesn't mean anything. CRP is again in a 1-year-old child is not of any use. And the last thing is starting antibiotic, amoxiclav based on some questionable rise in CRP and counts is irrational. Okay, Jagdish, your comments before we move to the next scenario.
No, I was only rooting for a urine routine testing, otherwise nothing. And I think whether the child is circumcised or not, I would do a urine test.
I'm just quoting recommendations. It's okay, fine. In India, we don't find that being prevalent as of now. Okay, right. Case 7. Next one, please, Krishna. Yeah. 2-year-old, fever 1 day, maximum temperature is 100 in the armpit. At 1 year of age, this child had simple febrile seizures. And the parents feel that paracetamol does not work well for their kid. But there are not only parents who feel, there are many pediatricians who feel wrongly that paracetamol does not work well for such children. And they start mefenamic acid with paracetamol BD. And they start tepid sponging if fever is above 100 degrees Fahrenheit. And they have an aunt in Dubai who calls and says, you please use paracetamol suppository. That is what they do here in Dubai for fever. They come to you. And the baby is well. Temperature is 100, but baby is well. What is your approach, Dr. Surendranath?
This child, sir, 2-year-old coming with history of simple febrile seizures 1 week ago. So most of the parents will be worried if there is fever, child will get convulsion. But the data shows that it doesn't correlate with the height of the temperature when the child will get the febrile seizures. So most of the febrile seizures may come at the onset of the fever itself. So she should give a paracetamol a proper dose. A proper company, reputed company is better always, because we have so many types of paracetamols available in the market. So try to give a reputed company, 15 mg per kg body weight per dose, and then check whether the fever is coming down or not. And combination of mefenamic acid, paracetamol should be banned. It is not recommended in any textbook, and this combination should be avoided and it should be banned in fact. So nowadays we are seeing a trend that some of the pediatricians, if the fever is 101 and above, they advise mefenamic acid instead of paracetamol. Definitely there is no advantage of mefenamic acid as an antipyretic, and it is not recommended as an antipyretic medicine. And not only that, the seizure threshold also was found to be increased by using the mefenamic acid. So coming to the paracetamol suppository, it can be used, but absorption of paracetamol from the rectum is erratic. It is not same as oral absorption. Sometimes it can be used, sir, paracetamol suppository, if the child is persistently vomiting, not retaining the medicine. In that situation, it can be used. So reassuring the mother, give proper dose of paracetamol and call her for the review as early as possible. Or if parents are worried, keep under observation for 24 hours and so on. But most of the time, they don't require admission.
Okay. Okay, Dr. Rashna and Dr. Abhay and Dr. Both of you, I'm going to ask both of you, what is the threshold number where you would suggest giving an antibiotic to such a child?
10.
They say, see, some doctors, I'll tell you from my experience, I can tell you, some doctors suggest, even if the temperature is 99, if there is febrile seizure, you better start paracetamol. Others say 100, you give paracetamol. In fact, I've seen advice given by doctors saying 100 means you give paracetamol, 101 means you give mefenamic acid, 102 means you do tepid sponging. What is your reaction in such situations?
Only if the temperature is above 101 and patient is uncomfortable, then you will use paracetamol. In this case, because the child had simple febrile seizures a year back, and we know that till 6 years of age, there is a tendency for the febrile seizures to come. So definitely above 101, we would give paracetamol, and only paracetamol. There is no point in giving mefenamic acid or combination, because mefenamic acid not only increases the seizure threshold, but also has nephrotoxic effects. So we don't want to use that. And if the baby is well, in this case, I think we'll just wait and watch and reassure the parents.
Dr. Sara?
I think in febrile seizures, rather than the height of fever, the rise at which the increase, that is more correlating with the risk of having a seizure. So probably I would also advise 101 and above for the fever to be. The fever rise, to prevent the fever rise, has been correlated with the onset of seizure. Anyway, the use of paracetamol does not prevent febrile convulsion. So I would probably...
your comments on this?
Yeah, so no, I will treat the same, whether the child has got the febrile convulsion or not. So my pharmacotherapy for the fever remains the same. Means if the child is uncomfortable, then I will give the paracetamol to bring the comfort. No amount of any antibiotic in any dose will prevent the recurrence of the febrile seizure. Lot of studies are now available. And as far as mefenamic acid, paracetamol is concerned, combination is a big no. Only paracetamol, paracetamol. But there is no clear-cut demarcation that 100 or 101. Every child has a different threshold to get the conversion. So I think I will treat as a common fever in a febrile child with a febrile seizure as well as without febrile seizure. So answer remains the same.
Do you recommend tepid sponging, Abhay, in your practice?
Yes, I do recommend the tepid sponging in a child who's got the febrile seizure and child who's got the heat stroke because it helps to reduce the temperature little down. But never mefenamic acid and paracetamol, never.
Okay. Jagdish, your comments, please.
Yeah, I think the key thing here is the parental anxiety.
Yeah.
I think the problem here, once a child has had a febrile seizure, there is a tremendous amount of anxiety. And we may be very purist in saying that give that paracetamol only above 101, but the parent is not going to listen to you. If the temperature is anything more than 99, they are going to give whatever medicine they have with them. So I think the important thing here is to counsel the parents. Three or four things. Number one, aggressive management of fever is not going to prevent a recurrence of febrile seizure. That is point number one. Point number two, paracetamol alone is more than sufficient to control temperature. You do not need additional medication. So you have to give adequate doses, and whether you use it orally or rectally, it really doesn't matter. It is a parental preference, because maybe we are in India used to oral medication, but if you go to a country like France, they don't use oral medication at all. Everything is per rectal. So I think the issue is that this is a parental preference. Why should you worry about whether they give it orally or rectally? It doesn't really matter. The only thing is that what is going to harm this child is mefenamic acid. So I think the important thing here is to tell them that mefenamic acid is harmful and strictly not to be used. They can use paracetamol in the right doses and in the correct frequency for the child, and also tell them that even with whatever you are going to give for fever, with the correct dose of temperature, the child may still get a seizure. That seizure is not a dangerous thing and they don't need to worry about it. I think the important thing here is parental counseling rather than worrying about whether they sponge or don't sponge. It really doesn't make any great difference. This is my viewpoint.
Agreed. Jagdish, do you advise tepid sponging?
Not really. I don't routinely recommend it. But if the patient is really anxious, I don't see any harm in their doing it. I don't think it does anything great, but it doesn't matter. It is one of those simple.
Okay.
I mean, it's one of those. It is one of those things that I think is controversial scientifically, but is accepted culturally. So I think we should just leave it and tell them, okay, you want to sponge. You want to put a little bit of Udiquilon on the forehead, please go ahead and do it. How does it matter?
Okay.
And sometimes fever.
I wouldn't say forehead, because I would tell them, if you want to do really tepid sponging, then please do a tepid sponging of the whole body.
Rashnaji, I agree with you, but socially and culturally, there are people who still believe that if they put a little bit of Udiquilon in cold water and put it on the forehead, the temperature will come down. I don't see any reason why you should object to that. It doesn't really matter.
Okay. Now, very, very nice points brought out by Jagdish. But I'll tell you my views on this. Maybe it may be contra, or it may be what do you call unconventional. When I find parents coming, like, in fact, I know one doctor friend of mine whose son had multiple febrile seizures. He's now a medico now. He himself is a medico now. He's a surgeon now. He used to get febrile seizures. He used to get around 10 episodes between the age of 1 and 5. And I still remember when he was 2, both the parents, both doctors, they used to literally keep the child in the bathroom under a shower all the time whenever there was fever. They used to be so paranoid about fever. And that so-called tepid sponging never prevented any seizure in that boy. But if you look at literature, whether it is tepid sponging or is it paracetamol suppository or adequate dose of paracetamol or ibuprofen or even the so-called benzodiazepine prophylaxis, they don't seem to have prevented febrile seizures. But the problem for me is that tepid sponging, yes, Jagdish says if they want to do, let them do. But I find most of the time they do the tepid sponging wrongly. But you must know when to do tepid sponging and how to do tepid sponging. Tepid sponging should be done preferably 30 minutes to 1 hour after giving an antipyretic. In fact, if you do tepid sponging at the height of fever, particularly in a child who has a fever due to something like UTI or malaria with rigors, already the child is feeling cold. If you do tepid sponging, it will start shivering so much, the parents will think that the child is convulsing. So that's not the way you should do tepid sponging. You must advise them to do tepid sponging. It must come in the temperature of the tap water during around August, September, like that, not during April, May. It may be warm. So the water must be tepid. And the other thing is you must do it 1 hour or half an hour after giving an antipyretic. And you must know where to keep those sponges and keep it correctly. And Edicolon, of course, Jagdish says if they want to use it, you can ask them to use, but I'm afraid it's unscientific. It should not be encouraged. And too much of alcohol can also get absorbed through the skin if you keep on rubbing. Even eucalyptus oil can be toxic if they keep. Many parents do that also. Having said that, I think we should spend a lot of time in such parents explaining the basics of febrile seizures and giving evidence to them that febrile seizures per se are not easily preventable with antipyretics. They don't do harm to your child. That's the way you go about. Let us move to the next case scenario, please. Case scenario 8. Okay, this is an open question. Okay, suppository we already discussed. Suppository, in fact, if you look at the data about paracetamol pharmacokinetics and pharmacodynamics of rectal paracetamol, is not superior to oral route. So unless, a child is for some reason is vomiting everything, you don't have to resort to rectal paracetamol. Case 8. Please go to the next slide.
No. 1 minute, Dr. Balasubramanian. If you go to France, they will say it is not as good as oral route.
Yeah, but the data on the
So I think it doesn't matter. I mean, it's not a big difference,
Okay.
whether you use rectal or you give oral.
Okay, fine. If somebody wants to use it, somebody knows the technique. And the mother says that my child is vomiting, I have to use suppository, I would give. But otherwise, I would not recommend suppository and tell them suppository will prevent febrile seizures.
No, it won't. That is known.
Yeah. Okay. Case 8. Yeah. 5-year-old child sustains a bruise and a few painful lacerations in the cricket nets. He has lots of pain. And you prescribe paracetamol 250 milligram 4 times per day for a day, and if needed for one more day if there is pain. The father is shocked. He is surprised. Sir, why would I give this? Will my son get fever, doctor? Why should I give a fever medicine for this? And my doubts are, paracetamol as pain reliever, is it really effective? And as pediatricians, are we underusing paracetamol for pain relief, or you think paracetamol is useless? Surendranath, please.
Sir, if you ask me personally, I prefer paracetamol as an analgesic also, not only antipyretic, analgesic also. One thing I'm a little scared about giving ibuprofen because of its side effects like gastritis. Not only that, sometimes very rarely we have seen Steven Johnson's also occurring. And safe medicines are available. I don't think I will not prefer NSAIDs over the paracetamol. I feel I am comfortable with paracetamol with a proper dosage. Definitely it acts as an analgesic. This is my personal opinion.
Do you think it's effective as pain reliever, Dr. Surendranath?
I feel that it is effective, sir.
Okay. Dr. Abhay, do you think pediatricians are using enough paracetamol for pain or not?
See, paracetamol has two important effects. One is antipyretic, which is abundantly used, overused, and misused at times. But as far as analgesic effect, I think it is absolutely underused. Now, studies have been shown that when there is a non-inflammatory pain, paracetamol is a wonder drug, I would say, because it's a lipid soluble. The plasma concentration is very fast to achieve. And in a non-inflammatory pain, I think it's a drug which is underutilized. So I have used it enough time and got a good result. Of course, if there is inflammation like rheumatoid arthritis, something like that, where the paracetamol is not going to be as good as a non-inflammatory. But as far as non-inflammatory pain is concerned, it's a good analgesic.
Dr. Rashna?
I think paracetamol works really well because I hardly use the other NSAIDs for pain relief. And yes, it is true that parents do get surprised and they ask the question that is it going to relieve the pain? And in my practice, I have found that it works really well. And this is one drug that I use for pain relief, even for post-operative patients. So this works well in my experience. And there are studies also which have shown that it works well. Yes, as an anti-inflammatory, probably not, because it doesn't have that much of potential, but as an pain relief, it really works well.
Yes, I agree with all the panelists. Paracetamol is excellent antipyretic and analgesic, though not so good as an anti-inflammatory. So I also use paracetamol in the daily practice, even for post-op pain. It works well.
Okay, I want to ask the panelists, have any of you given paracetamol for abdominal pain?
Yes, I have given. Recurrent abdominal pain, when they come with these non-specific abdominal lymphadenopathy, I have used paracetamol very frequently and it works.
But commonly, pediatricians prescribe dicyclamine and or anticholinergic drugs for abdominal pain. They should be prescribing paracetamol. It's an excellent pain reliever. Of course, it won't work so well for visceral pain. When we don't know the cause for abdominal pain, paracetamol will not harm. And the other important point one must remember, paracetamol can be given to children even with hepatitis. It's not contraindicated. Paracetamol is not contraindicated for anybody who has fever or pain if there is hepatocellular failure or hepatocellular jaundice. You can use the same dose, nothing will happen. In fact, on the other hand, NSAIDs are dangerous in patients with hepatocellular failure. Paracetamol is pretty safe. Dr. Jagdish, your comments.
I entirely agree with the panelists and you on this, that paracetamol is an excellent analgesic. The only, of course, you're going to touch this on subsequent slides, so I'm not going to go into that now. But IV paracetamol is much better than the oral formulation for pain relief, especially because it modulates it through the central mechanisms. So it is definitely a very, very good pain reliever, no doubt of it.
Okay. To take over, Jagdish, from case scenario 9.
Thank you. So now we go to case scenario 9, and we'll start with Dr. Rashna. A child undergoes appendectomy and is on nil oral feeds, has severe pain and fever 102 degrees. Do you recommend IV paracetamol? What are the pros and cons of IV paracetamol?
Yes, I do recommend IV paracetamol. The only thing is the dose of IV paracetamol will be less than the dose which we use for oral. We give it slowly, not as a push, and it works well. So I think we just have to be careful about the dose.
Yeah. Any other comments from Dr. Sara?
7 to 7.5 milligram per kg, not.
I think that 7.5 milligram per kg is for children less than 10 kg.
Yeah.
So when the weight is more than 10 kg, you can go ahead with 15 milligram per kg. And what is recommended is that it should be given as a slow infusion over 15 minutes. But of late, there has been studies which says that even push is safe. You need not, have to monitor the child for 15 minutes. You can even do it as a fast push within 5 to 10 minutes. Regarding the pros and cons, of course, the onset of action is much faster. It acts within 5 to 10 minutes. And it has much greater analgesic effect than oral route. And it decreases the opioid use when use it along in post-op cases. So it is definitely good. And the demerits would be, you must always think of, the rare thing of anaphylactic reaction like hypotension and rash and malaise may be seen. Need to monitor the patient when you're giving paracetamol, and I may not use it if there is a hepatic impairment. And I would be careful in malnutrition and dehydration when I use IV paracetamol, if the child has underlying malnutrition.
Thank you. I think that was very comprehensive. Dr. Abhay, you want to add anything?
No, all points are. I think it's one of the best analgesic IV paracetamol, and that is the only. But it should be used in an ICU setting and to take care of the hypovolemia. So correct hydration is very, very important. Otherwise, child will end up into hypovolemia.
Dr. Surendranath?
Yes, sir. As a post-operative analgesic, it is the best when the child is a nil orally, where we cannot give orally. Definitely, it can be.
So I think it has overtaken much of the NSAIDs and the non-narcotic analgesics, because it's an extremely good analgesic, and most of the patients who are post-operative are on IV paracetamol. Okay, so we'll go to the next one.
Dr. Jagdish,
Yeah.
what about IM paracetamol?
Beg your pardon, I didn't get.
IM.
Intramuscular paracetamol is still widely available.
Yes. In fact, somebody has asked a question also about intramuscular.
So any of the panelists can take it?
I don't use it, sir, because I find that it's quite painful and erratic absorption. Rather, I would go for per rectal suppository in case you don't want to use IV paracetamol in this particular patient.
Dr. Abhay wanted to say something?
No, I think if when the hemodynamic child is not good, I think there is always going to be erratic absorption for intramuscular. So either we'll go for the IV or we'll go for the oral or rectal. So first choice is oral. But if the child is nil orally or if the GI motility is not there, you can give this parenteral IV, but not intramuscular.
Okay, Dr. Sarah.
Yeah, the
Dr.
same.
Sarah,
I would say the same. I would never give IM.
yeah. So IM is yes. Dr. Bala has used IM paracetamol.
No. IM paracetamol actually is an oily preparation, very poorly absorbed. Bioavailability is inferior to oral. It is extremely painful, and it can form a granuloma like DPT, and it should never be used. I'm surprised that it is still being marketed and used and abused. We have now in a sick patient, in an ICU patient, we have the alternative of IV paracetamol. In a stable patient, we have an alternative of rectal paracetamol. We should not be using intramuscular paracetamol.
Thank you. So now let's go to, can you move to the next slide, please? Yeah. Now this is a child, Dr. Abhay, the NRI child, 2-year-old from US, fever one day, paracetamol given, not better, ibuprofen given, and they have this combination of ibuprofen with paracetamol. Is it better to give this combination for relief of fever and pain?
Never ever. I think message is loud and clear that paracetamol is the drug of choice. In a correct dose, that is 15 milligram. If child is not responding, you can give little higher dose, that is 20 milligram per kg. But please do not overdose. There should not be a dose, should not be more than 60 milligram per kg per day. So number one, that paracetamol is we have to reassure the patient. We have to comprehensively look at the child. How is the comfort level? How the child is feeling? Whether the fever is coming down or not? What is the urine output? What is the oral? All these factors are to be considered. Just bombarding antibiotic one after other will increase the toxicity, will increase the gastritis. It is the main hepatotoxic drug, nephrotoxic drug. So if the hydration is not good, probably child may end up into an acute kidney injury, or sometimes it may be some acute hepatic encephalopathy. So I think overdosing and combination is not required. Sometime in US they give alternate paracetamol and ibuprofen, but again the difference is hardly 0.5 or 1 hour as far as the fever response is concerned. So I think fever, paracetamol 15 milligram per kg, if no response 20 milligram per kg, and that too every 6 hours is my drug of choice. No ibuprofen and no combination at all, because they are not accepted also, the irrational combination, fixed combination. Yeah.
So I think you're talking about three different things here. One is what is called as combination given together, that is in the same formulation you have both. The other one is sequential use of paracetamol with ibuprofen.
Yeah.
And the third is you don't use paracetamol at all, use only an NSAID.
No, so I use only paracetamol, that is in a right dose and can be repeated 6 hourly. And in between the two dose, child should be observed. If it taking well, his comfort level comes, discomfort level comes down, no worry. But if the child is not responding, there is no point in giving the combinations. Means the fixed combination, big no. In US, sometimes they give fever, ibuprofen and paracetamol alternative. But again, I'm not in favor of that. I only use paracetamol. That is my message.
Dr. Rashna, you want to comment on that?
I use only paracetamol. Ibuprofen I use only in my pediatric rheumatology cases. Otherwise, I don't use ibuprofen at all, and never a combination, because when you give the combination, the doses of both the drugs are not in the right proportion. So you cannot give, and one of them becomes more higher than what you need to give. So therefore, we never use it. I never use it in my practice.
But have you ever used it and found it effective in bringing down temperature adequately? Dr. Surendranath now, let's ask him whether he has given it at all.
No, sir. I prefer paracetamol only. Paracetamol proper dosage, definitely it works. If it is not working,
sometimes you must have used ibugesic, no?
Sir?
Sometimes you must have used ibugesic. Somewhere, some parent must have told you fever doesn't come down with paracetamol.
Yeah. NRI patient, they come with two types of bottles, sir. One is Mortin, another is, what is that paracetamol? Tylenol. They bring these two bottles, in fact. They always say that if Tylenol is working, alternative they give Mortin. But I prefer in my practice, I'll not write NSAIDs. I'm little scared about those things causing complications. So I'll never write. I'll prefer paracetamol on this.
Dr. Sara, do you use ibuprofen at all?
No, I prefer paracetamol, but there has been RCTs which shows that ibuprofen does have a little higher antipyretic effect. There are many studies which has come up on that. There is, maybe, but personally, I would like, and the message is that, and for the first line antipyretic is paracetamol.
Thank you. So, Dr. Balasubramaniam, any comments from your side?
Yeah, two comments. Paracetamol and ibuprofen both are approved for antipyretic therapy beyond 6 months of age. Ibuprofen is not recommended below 6 months. Paracetamol, as per manufacturer's recommendations, is not recommended below 3 months of age. In terms of efficacy, most studies have shown equal efficacy, with a few studies showing better efficacy of ibuprofen. But in India, where there are two problems which prevent me from upfront use of ibuprofen. One is dengue. Second, the Indian culture is such that a child who has fever is never given enough food. So a child who's already starving because of the febrile illness, with mother giving less nutritious food than before during the febrile illness, if you give NSAID, there is always a chance you may hurt the GI tract. So it is better to prefer paracetamol. Having said that, if the parents are comfortable, there are quite a few of my clients who tell me, sir, I am comfortable with the ibuprofen. My son is happy with that. I want to use it straight away. First 2 days of fever, there's no harm in giving ibuprofen if the parents want to prefer, but I don't prefer ibuprofen upfront. Combination, no. The other important point that one must remember, you can have allergy to ibuprofen, and I have seen allergy to paracetamol also. So both can occur. So whatever the child tolerates better, use that. In fact, I know a few patients who don't tolerate paracetamol. They develop urticaria. I use ibuprofen in such way. They tolerate. And vice versa also. Ibuprofen causing urticaria. Both can happen. The only thing that you have to be careful in giving ibuprofen is to tell the parent never give in an empty stomach. Paracetamol maximum dosage also has to be told to the parent. Maximum dose is 75 milligram per kg, not more than 5 doses of 15 milligram per kg.
Thank you, Dr. Balasubramaniam. Next slide, please. Okay, now we have case scenario 11, which I think Dr. Surendranath can take. We are anxious parents, 1-year-old with fever for a day, give paracetamol 5 ml, that is 1 ml is 100 milligram, 4 doses in 24 hours. So how do you proceed and how can this be avoided?
We have to, first thing is we have to explain the strength of the medicine whenever we are writing to the patients. So in India, we have a lot of problem because 1 ml will have 100 mg, 5 ml will have 120 mg, 5 ml with 250 mg, 5 ml with 500 mg is also available now. So it is always better to explain the parents when you are writing the medicine and be careful while administering the medicines. So this child, a 5 ml dose of 1 ml is given, 100 mg, that means 500 mg 4 times, almost 2 grams of paracetamol is given. A child is 1 year old. If you take the weight, let us hope that average weight of Indian child is around 9 kg. So he has received almost about 200 milligrams of paracetamol over a period of 24 hours. So 200 milligrams over a period of 24 hours is definitely a toxic dose for a 1-year-old child. Definitely 2 grams dose is 200 mg per kg is supposed to be toxic. if it is taken within 24 hours. So I think we have to monitor this child, admit him and monitor this child for any complications of paracetamol over, toxic dose of paracetamol, because child is only 1 year old. So liver treatment will depend on the estimation of the paracetamol, but I don't know how far it is available in India. Now, I think many labs are doing, so we can do. And tell the mother that the overdose might cause some problems of the hepatic problems, which can be solved by giving proper drug. So this is what we have to do, I think.
But the mother says, see, the child is absolutely normal, doctor. Why do you want to keep the child in hospital?
I think paracetamol ingestion, toxic ingestion takes some time to manifest. Initially, there may be a little vomiting, nausea, but a hepatic manifestation will take some time. So we have to explain them the risk of this complication and admit them and observe them.
Yeah. Dr. Sarah, can you add on to that?
Yeah, I think this 1-year-old child has taken a dose something like 200 milligram per kg per day. I would be worried, and I would be starting this child on N-acetylcysteine.
Absolutely.
The first dose, loading dose, would be 150 milligram per kg given over 15 minutes to 1 hour. And subsequent doses, maybe another dose of 50 milligram per kg over 4 hours, and then again continue for another whole 24 hours, another 16 hours, maybe the third dose. I would definitely treat this child upfront, because even if you need to give N-acetylcysteine, you need to give it within 4 to 6 hours. So there is no point in starting that late. And when we are very sure that he has been definitely paracetamol overdosed.
True. Agreed. Dr. Abhay?
Yeah, so it is not only the dose, but the duration is also important.
Duration, yes, exactly.
If the more than 4 hours has left, I think it is an ideal case to start the NAC upfront. So I agree with Dr. Sarah that the NAC is required here.
Dr. Rashna, you want to add anything?
No, I think everyone has covered the topic quite well.
Yeah, I think Dr. Balasubramaniam can have a final word and we'll move to the next.
Just only one comment. Please use only one strength paracetamol for convenience. And I believe that the drops or that 500 milligram per 5 ml or even 250 milligram, we should not be prescribing. And once we prescribe, we must actually talk to the parents, tell them the maximum dose they can give, and also tell them fever can be less dangerous than overdosage of paracetamol. That's what I would do.
Right, sir. Thank you.
Just one thing I want to add, that always ask the parents to use syringe rather than measuring cup when the dose is less than 5 ml. Because the spoon and the measuring cups can, the dose, if we need to be very accurate, that is one way to educate the parents in small children to always use a syringe for measuring, especially for measurements less than 5 ml.
Thank you. Yes, absolutely. Or use the dropper.
Yes.
Okay. Can we go to the next scenario? Yeah. So now I think this is for who's the next person? I think we finished it. Dr. Abhay has to take this, I think.
Okay, please.
So this is a 1-year-old with 5 days of biphasic fever on paracetamol for 5 days. On day 3, the young pediatrician does a CBC Vidal. The Vidal is 1 in 80. That counts are 4,000 with the polymorphs of 60 and lymphocytes of 40. So this is a slide test. She started with ofloxacin and cefixime. Your comments and suggestions.
So there are multiple errors in it. So first I will go with the history. I think fever, which is a biphasic, there are very few viral infections that is a biphasic fever. So when in our tropical country, especially in the monsoon, I think I will think of the dengue and chikungunya and sometimes lepto. Now paracetamol given on the 5 days child should be all right. And if you look at this counts, there is no platelet count which is available here. So I need to look at the platelet count. Vidal slide test or even tube test, I am not, I would straight away go for the blood culture. So if I have got a child who has got a fever which is more than 5 days, even if it is a biphasic, I will do the blood culture first. And accordingly, if the clinical, I think that is the case of a enteric fever, I will start with the septic. But here the fever is biphasic, so enteric less likely. Even if I am suspecting enteric fever, I will go for the blood culture. That is very important. And because blood culture is gold standard, Salmonella are easy to grow. Number two. Number three, slide test. Even if it's a tube test, it has no meaning to me. 1 in 80, it should be in a higher titer. It should be a fourfold rise and a rising titer, which is very difficult to follow. It will be available positive by day 7 and day 10. And by that time, the diabetes will be obviously clinical. So I will look at the clinical examination. I would look at the community, what is happening there, look at the season, what is the vaccination of the child. All these factors are very, very important to analyze this child. So again, I'm not dealing with a case of typhoid fever, so forget about 2 antibiotics. I will not start even ofloxacin. That is very important. But at the same time, I will look at it, whether the child becomes dull or not with the defervescence. So if the child is become dull, if there is lethargy, if there is vomiting, if there is abdominal pain, if the platelets are falling, if the hematocrit is rising, probably this biphasic fever is to me dengue, and I need a good IV fluid therapy rather than any antibiotics.
So in this child, what would you do, Dr. Abhay? Would you
Yes, I will go for the.
Would you admit this child?
Yes, if the child is, there is no other symptom. If the child is vomiting, is sick looking, I will definitely add. But if the child is comfortable, I will explain the reflex sign, ask him to give plenty of fluids, ORS, coconut water, lime water, and only paracetamol. And will explain if there is vomiting, abdominal pain, if some rash is developing there, then the child should come. Or edema is there. If they reduce in output, I will ask them to come back.
Dr. Surendranath, what would you do here?
Biphasic fever mostly suggestive of the viral infections here, as you have clearly mentioned. Had it been a continuous fever for 5 days, definitely I'll think of some enteric fever or other problems. Then we will investigate properly and treat him. But a biphasic fever, I think we can wait for 1 day or 2 days more. So sometimes viral infections may get on their own by 5th or 6th day. So monitor the temperature, give paracetamol, observe for 1 more day. If the child is not sick, as Abhay sir told that if the child is looking well without any symptoms of toxicity, I think we can wait for 1 more day. There is no hurry to start ofloxacin cefixime for this child.
Dr. Rashna, your comments?
I think biphasic would be viral if it's in a epidemic area, maybe dengue would be something which will come to my mind because that can explain it. And I'd still continue with paracetamol because the Vidal is, we know, not reliable and that by slide. And it's not a good test. And I would not start on ofloxacin and cefixime. I think I'd observe. And if it's a 1-year-old child, again, the urinary and the culture would be important in this child.
Yeah, I think, Dr. Sara, I would think that the ideal thing here would be to start on an IV ceftriaxone and keep this child under observation. What do you think, Dr. Sara?
No, before coming to that, I would like to have his hematocrit and platelet as well, which is not given. Vidal, I would never do. And with the history like this, I would straight away would want to establish a diagnosis. I would go for an NS1 antigen and IgM upfront before doing anything. And if it is dengue, then the treatment is obviously clear. Differential here is either it's enteric or dengue, but the biphasic fever, as it is put, points more towards a dengue. So I would refrain from. I would first get an NS1 antigen and IgM here, and then decide.
Can I comment?
Yes, please.
I think day 5 NS1 is little late.
Late, but IgM, okay.
If it is positive,
On the higher side, yeah.
IgM may helpful. So it's an ideal case to go for the dengue PCR.
Yes, that was it.
Yep. So in this child, you would admit the child, keep the child under observation, send off the investigations, and not start an antibiotic. Is that right?
Yes, sir.
Okay. Dr. Balasubramaniam, any of your
2 or 3 comments. Okay. No. Please go to the previous slide. Only 2 comments on the previous.
Yes.
Case 11, please. Krishna?
No. This is case 12.
No, case 12 you're discussing.
Okay. We'll move on to the case 12 then. Okay. Case 12. You want me to do with the Jagdish? You go ahead.
The same case continues, Dr. Balasubramaniam. You can continue.
Okay. Sorry. Case scenario. You continue, Jagdish.
Okay. So now let's go ahead with this case further. And here, this child continues with the cefixime and ofloxacin. There's no fever. Mother feels the limbs are chill. There's poor intake. There's increased lethargy. Parents are happy there's no fever. Are you happy, Dr.
No.
Sara?
No.
Definitely not. This obviously he has gone into dengue shock now.
Yes.
Most probably the way the case has been evolved. His extremities are cold. He's lethargic. So he looks to be shocky. And that would be my diagnosis.
So I think the drop in fever actually is an ominous sign. And I think,
Yes.
I think we should be guarded against it. Okay, let's go to now we hand it over to Dr. Balasubramaniam. You can take over from the next slide.
Okay, go ahead. Case 13, 2-year-old with fever for 2 days. Grandmother stops all solids and suggests glucose oral and dilute milk and kanji. Father wants to give ORS because it is summertime since he feels that he will become dehydrated. I'm going to ask Dr. Rashna, what should be the correct do's and don'ts with regard to feeding during an acute febrile illness? How do you go about it?
I think this is a very important part of management in the OPD. If there is fever, first of all, manage the fever if the child is uncomfortable. If the child has good appetite, then we do not do any change in the diet. The only thing we advise is plenty of oral fluids and not glucose or dilute milk or kunji as has been given here, because glucose will not help. Dilute milk again is not good. So if the father wants to give ORS, then we have to make sure that it is the WHO approved ORS. If the child doesn't like ORS, then at least more fluids or homemade, the other fluids can be given like coconut water. The don'ts are don't stop feeding. Number one, do not try to restrict any kind of diet because this will otherwise increase the dehydration and the child will get, feel more sick. And there are a lot of concepts.
I find many times.
Yeah, and there are a lot of concepts. Yes, sir.
Please go ahead.
And there are a lot of loco-regional concepts with the parents. So that I think for locally, whatever some of them will not give this, some of them will not give cold foods. So I think those kind of things we have to find out in each area and then tackle that individually. Because some things are followed in part of the country, some things are followed in other parts of the country. Yes, sir.
Many a time I find mother-in-law saying, don't give orange juice, whereas the daughter-in-law say, don't give kashayam. The mother-in-law wants to give kashayam. There are conflicts. Dr. Surendranath, how do you manage all this? They don't want to give juice. They don't want to give rice. They don't want to give fruits because the child will catch cold during fever. How do you handle this?
I usually explain them, sir, when they come for fever, whenever high-grade fever is there, I'll tell them to give the liquids is very important and continue the feeding whenever the child feels well. In between the fever, whenever fever comes down, try to give the food, whatever amount she takes in a number of times, small quantity if he's liking, give more number of times. Normally, I tell them to maintain the dehydration. So dehydration has to be corrected whenever fever is there. So I tell them homemade liquids like coconut water. A plain coconut water is best to give for the children who like it. And I don't know about plain glucose oral. I have never advised. Only thing is WHO ORS also I have some concern because there is no diarrhea and vomiting. Should we use it for fever? Normally, it is only recommended when there is acute gastroenteritis like situation is there. So nowadays we have some commercial ORS, which is not WHO ORS in fact. So when I looked into the contents of the ORS, which is not the WHO, because it is promoted in the counter across the counter, which has almost a sugar content of about 130 grams per 1 liter. So there is some amount of calorie intake will be there if there is no GE losses. Gastroenteritis, some situation is not there, maybe we can use them. It will increase the calorie intake little bit and give some electrolytes to them. So this is what normally I tell them, sir. Homemade preparations are preferable. If the child is not able to take anything, maybe this high sugar content which is available sometimes may help to reduce the dehydration, especially in dengue. Dengue high fever will be there, intake will be less. child will be going into the dehydration. Preferably explain them to have more number of feeds with the liquids. Say plain water intake is also very good, but most of the time the vomitings are there. It is very difficult to convince them.
Quick comments from Sarah and Abhay.
I think
Child normally will have some loss of appetite with the fever that is expected. So what I would tell them to give whatever the child accepts, not to force something to the child. So whatever solids or semi-solids with the child can take should be encouraged with plenty of fluids.
Dr. Abhay.
yeah, so hydration and nutrition both are very, very important in a fever management. Because of this, if the hydration is not properly correct, I think it increases the toxicity of the antipyretic drugs. And if we do not give the nutritional soft small diet which is available in the home, and what the child likes is very important. So there is no food restriction. But if the appetite is not that good because of the fever, I think we ask them to give some homemade fluids, some fruits, some fruit purees, all that can be given. So no dilution of the food, no dilution of the milk. Your breastfeeding child, always continue the breastfeeding child. It is very, very important.
Okay, well said, Dr. Abhay. I think one of the important factors we should remember before giving ORS is that ORS is indicated only for gastroenteritis, dehydration, and dengue. The PCV is high, you can treat with ORS orally. Okay, in the Southeast Asian countries, where when they have loads of cases of dengue, like diarrhea management cells, they have ORS cells for giving oral rehydration therapy for children and adults with dengue who have high PCV. But other febrile illnesses, we should not be giving ORS, and as rightly pointed out, commercial preparations which are non-WHO should not be used for anything. They are not recommended. In fact, the high glucose content may make the child vomit and make the child become dehydrated. And all the food fats should be avoided during acute febrile illness. Okay, let us move on to Jagdish, your comments on 13 before we move on to 14.
I think the points are well brought out. The important thing to note is that there is a 7% increase for every degree rise in temperature, 7% increase in fluid requirement. So I think this is normally forgotten by parents because the child has naturally anorexia and also is vomiting during an acute bout of fever. So it's very important that the parents are told that even if the child does not drink large quantities of water, to keep feeding small spoons of liquid, any kind of homemade liquid is fine, but the child should be fed frequently rather than large quantities at a time.
Yes.
This is very important because most parents don't do it. They will try to fill a full bowl of milk and try to give it to the child. The child will just refuse to take it. So I think the counseling of the parent is very important in this fluid management part.
Very well said, Jagdish. Let us move on to case number 14. A 3-year-old gets fever over 10 times in the last 1 year. And the parents are asking you, sir, is there something wrong with my child's immune status? Can you do something to improve his immunity? It's a very frequently asked question in our chambers. Am I right? Jagdish, you get these questions, isn't it?
Very much, very much.
Yeah. And they are worried whether the child is having some immunity problem. When should we worry in such situations, Dr. Sarah?
Firstly, I would like to ask whether the fever had any accompanying symptoms. Was it like upper respiratory infections or anything else which is causing the fever? Otherwise, I would take more than 3 episodes of unexplained fever in 6 months. So by that standard, if you look, definitely more than 10 episodes in unexplained fever in 1 year, I would consider it significant.
Okay, how do you go about?
So history is very important, sir, here. You need to get a history about what was the type of fever, what were the interval between the 2 febrile illnesses, what were the accompanying symptoms, and whether this child has, age of the child also is very important, at what age the symptoms started, and whether the child has associated symptoms like any pneumonias, sepsis, gastrointestinal symptoms, etc., to substantiate the diagnosis or the suspect of immunodeficiency.
Okay. Yes. Dr. Abhay?
Yeah, so I will look. I will look at the detail of the each episode. Number one, how it started, how it responded to paracetamol, and whether it has affected the weight of the child, growth of the child, whether the child is anemic, whether the child has got hepatosplenomegaly, whether the child has lymphadenopathy, whether the child has some joint. So I think it is very important. If the child is absolutely normal, 8 or 10 fever in a child who is otherwise growing well, has no red flags on clinical parameters or lab parameters, I would not worry. But if any of the red flag is present, suppose there is faltering in the growth, I am worried. If there is a new appearance of the hepatosplenomegaly, I am worried. If there is lymphadenopathy, which was previously not there, I am worried. But if everything is not there, any simple viral infection, simple viral URI and fever, I think 8 and 10 infection per year in a well-growing child, I would not worry.
Sir, I wanted to add one more thing. I would look at the periodicity is very important here. Whether is it coming at regular intervals, because it can be periodic fevers which can, or PFAPA, etc. So that is one thing we need to look at, whether it's coming at some particular definite pattern.
Okay. Dr. Ashna?
Yeah, I think most of the points have been covered. We have to know about the 10 red flag signs of an primary immune deficiency. If none of those are fitting in, then we don't need to worry. So how many times the child has got fever with other system involvement? Has the child been admitted for more than 2 pneumonias in a year? Those kind of things. And I usually tell my parents, the parents of the children who come to me, that if a child is mounting a fever, it means that his immune status is actually good. Because of his good immune status, he is responding to every viral infection. Otherwise, you would not have fever if you had some problem. So I think we should not worry in such situations if it's only fever with no other major system involvement. And the history is very important, as everybody has said, history of fever with viral infections, those kind of things, because in this period, viral infections are the most common. And our textbook of pediatrics itself says that 8 to 10 episodes per year is normal.
Dr. Surendranath?
As all of them told, that history is very important. The point is whether any hospitalization has occurred during this period, whether any IV antibiotics has been used for every fever for a prolonged time, that goes in more favor of a immunodeficiency. Definitely, there are certain criteria to define immunodeficiency: how many episodes of pneumonia, how many episodes of fever, how many episodes of sinus. Something like that is there. Provided the child growth is normal and child's weight is normal, no failure to thrive. In that case, a community-acquired infections which are transient in nature subside by 3 to 4 days, we need not worry about any serious problem unless red flag signs are there. Sir. And regarding the immune status, ask them to do all the vaccines which are available so that they can prevent some of the infections. And I advise them to take all the vaccines which are advised by the central IAP, ACVIP, and monitor the child for any red flag signs.
Very well said, all of you. Now, any child who has so-called recurrent infections or frequent infection, of course, as pointed out by the experts, because you should get a good history, assess the growth and development, check what is the type of fever, hospitalization, IV antibiotic, etc. But then when you talk about the causes of children with frequent infection, there are only four groups we must know. One is, the most common group is a normal child. 50% of those who get recurrent infections or frequent infections are normal. You had Andrew Bush of the United Kingdom, a pediatric pulmonologist. He says 15 respiratory infections, URI, each causing symptoms for 15 days, 225 days a year, child can have symptoms. But if the growth and development is okay, don't worry, it's a normal child. The most frequent cause for frequent infections is the child who's normal. For some reason gets infection, it may be daycare, it may be paternal smoking, etc., etc. That's one, group one. Group two is the child with atopy. asthma, allergic rhinitis, that where the child gets a lot of symptoms when there is infection. Group 3 is an anatomical barrier or a barrier failure. For example, you have mucociliary disease like cystic fibrosis. You have primary ciliary dyskinesia, etc. Chronic aspiration syndrome. That is group 3. That's about 10%. Last group is your immunodeficiency, where Rashna said 10 warning signs. Dr. Surendranath said IV antibiotics, failure to thrive, family history, etc. I think these are the 4 groups, and we must get a good history and then classify the child as to which group this child falls into before we start investigating. Dr. Jagdish, your final comments on this.
Yeah, I think I was about to say the same thing, that you need to divide this 3-year-old into various groups. Vast majority will be normal children. And you will see that these normal children are getting these recurrent infections due to something in the environment. It could be a crowded environment at home. It could be daycare. It could be smoking, as you said, passive smoking. It could be any of those. Many of these children could have chronic adenoiditis, and keep getting frequent ear infections and sinus infections. Another thing which one should never miss is a child who has got recurrent UTI. Because many times what happens is the child is with fever, is given some antibiotic, recovers for some time, comes back again with a UTI, again is given some other antibiotic because the previous antibiotic didn't work, but a urine culture is never done. So I think the thing is that the biggest problem will be to miss a UTI which is going on for a long time. So I think the thing has to be, we have to put this into perspective, look at it in detail and see which group this fits into. Immunodeficiency disorders are uncommon. And as Dr. Sara mentioned, the autoinflammatory disorder is also not a common thing. You will find them. But I think important thing, as she mentioned, is taking a good history to see what is the periodicity and then looking at referral. So I think this child could fit into a whole box, Pandora's box, and it could be any one of those things. I think a good clinical evaluation is most important.
Okay, let us deal with the next scenario. Last scenario, case scenario 15, please. Yeah, quickly we'll finish this. It's a 10 weeks infant. It receives hexavalent vaccine, PCV and Rota at 6 weeks. Parents want to give paracetamol for a day. They have come for a vaccination to your clinic. You're about to vaccinate the child. The parents want to give paracetamol for a day to prevent fever and pain because they had a horrible time at 6 weeks because the infant went on crying and had high fever during the last dose. They want to prevent this and they want to give paracetamol. Okay. Dr. Rashna, is it okay to give it prophylactically? What are your thoughts?
It's not okay to give prophylactically.
Why?
Yeah, because it is not going to, first of all, the patient may not have a response to the vaccine this time. We would be unnecessarily using it. Secondly, it is when you give the paracetamol beforehand, the vaccine efficacy may be affected. And I only advise them that if the fever or the patient becomes uncomfortable, then only you will use the dose. Otherwise, they'll end up giving unnecessarily, and it may not actually work well for the child as far as the vaccination is concerned.
Okay. When do you give paracetamol after vaccination?
Only if there is a history of excessive crying in the last episode, incessant crying because of the fever and discomfort, then only you will advise. I would advise that if this time also you feel that the temperature is rising, baby is getting uncomfortable, then you will give the paracetamol, or the baby is having problem in moving the limb.
Dr. Surendranath?
Yes, sir. I agree with Rashna, madam. Prophylactic paracetamol has shown that immunogenicity, it will affect immunogenicity of some of the vaccines. There has been evidence that prophylactic paracetamol will definitely blunt the immunogenicity of the vaccine. So absolutely prophylactic paracetamol is not recommended. Only when it is required, if the child is irritable, pain is more, fever is high, then we can give the paracetamol. That's what
Jagdish, your final comments before we take the questions in the chat box.
I have one comment, sir.
Yes.
Yeah.
Specifically,
please go ahead.
Specifically, it decreases prophylactic paracetamol or any analgesic will decrease the antigenicity of the pneumococcal vaccine and the pertussis. That is two important vaccines. So in general, they recruit once there is no, you give the analgesic or anti-inflammatory agent prophylactically, it will prevent the migration of the dendritic cell to the site of lymph node. And that's why the antigenicity of the vaccine is poor. So I think it do more harm in terms of antigenicity and will not prevent the occurrence of the fever, pain, and the swelling.
It's not recommended, rightly
Not
said, Dr.
recommended.
Abhay.
Not recommended.
Dr. Jagdish, your final comments on this question, and then you can take the chat box
I think
questions.
I entirely agree with Dr. Abhay that prophylactic should be avoided, but at the same time, any kind of discomfort and the child crying incessantly or not sleeping should not be a reason for not giving paracetamol. I think the important thing is you have to balance between the two. The middle path is most important. You can't overdo either giving paracetamol or not give paracetamol to a child who really needs it.
Okay. Jagdish, with this, we'll conclude this, and you can take the chat box questions and other questions.
Yes, sir. Thank you, sir. So I'll start with a question from Dr. Rajendran. He asked whether intramuscular antibiotic in a neonate is advisable.
No, never ever.
No, not at all.
Okay. So next is Dr. Reddy says important clue is urine output. We entirely agree with you. Then Dr. Karunakar from Warangal likes to know whether diclofenac is recommended for high fever in children.
No.
No. All panelists says no, Dr. Karunakar. Dr. Niranjan Mohanty Katak says.
Jagdish, one comment.
Yes.
Interestingly, I don't use diclofenac, nor recommend diclofenac. Interestingly, diclofenac suppository has been studied in one of the trials for prevention of febrile seizures, and they compared it with oral antipyretics, and they found, of course, I'm quoting the study, I'm not recommending it. They found that diclofenac suppository was better than oral paracetamol. But having said that, diclofenac is a dangerous drug, as dangerous as mefenamic acid or nimesulide. Please do not use it for fever.
Now, in fact, diclofenac has gone out of the market because they were using it more in the agricultural farms, and it was causing a lot of problems with the, when the dead bodies of these agricultural, like cows and all, were
animals
by the vultures. The vulture population went up because of renal failure, and that was affecting the ecosystem. So now diclofenac has been banned because of that, and therefore it is not very easily available as it was before.
Unfortunately, syrup is also available, madam.
Pardon?
Unfortunately, diclofenac syrups have come into the market.
We should not prescribe it. This is a very serious environmental issue.
Yeah, you're right. Vultures, the Parsis, they leave the bodies to the vultures. I believe many vultures in Mumbai have died because of diclofenac. You're right.
Yeah, you're right.
Parsis take diclofenac, Dr. Balasubramaniam.
Pardon?
Do Parsis take diclofenac?
No. Diclofenac is taken.
Okay. That was a lighter note.
Vultures.
Okay, Dr. Niranjan Mohanty Katak says that IMNCI also approves feeling warm by seeing on upper hand, abdomen by dorsal part of the hand. What are your comments? I think Dr. Surendranath can take that.
Yeah, that is only for the newborn, sir, to know whether it is a cold stress or hypothermia. Just to differentiate whether it is a cold stress or hypothermia, that recommendation has come. I think we have to measure the temperature to know whether that is hypothermic or not.
And Dr. Nandish asked for a reference for using auxiliary temperature after infrared temperature. I don't think anybody said that, but anyway, we'll pass that. One Dr. Datta asked, what if ibuprofen alone or in combination with paracetamol if fever does not respond to paracetamol alone? I think that's already addressed.
Discussed.
Dr. Anand Vasudev says tepid sponging, if at all, is to be done. Best would be to use the water they use for bathing. The child in the particular weather, tap water or warm water may be uncomfortable in hot weather. Noted, sir. Thank you very much. Dr. Niranjan Mohanty Katak says Stevens-Johnson syndrome more in paracetamol or ibuprofen?
Ibuprofen.
Ibuprofen.
More with ibuprofen.
Yes, more with ibuprofen. I've got 2 cases.
Okay, so there's another question asked, how frequently can paracetamol be given in fevers? Dr. Mallikarjun,
If dose is 50 milligrams, 6 hourly.
6 hourly, fine.
4 or
Dr.
6 hours. Maximum dose is 5.
Previously, we were using 10 mg per kg, where the permissible dose is 4 hourly. Now the science has changed, it's 15 milligram every 6 hourly.
15 milligram. You can give 4 or 6 hourly SOS or fever or pain. You should not exceed 75 milligram per kg. That's all.
Dr. Ravindra Ramakrishna Joshi asked whether scope for paracetamol injection in children already addressed. Then Dr. Dheeraj Mohan Gupta Varanasi, is oral paracetamol is more effective than IV.
No,
I think,
No. IV is more.
Then
For
another one is
pain,
on mefenamic acid, which we have said no. Then Dr. Vipul Shah asked whether oily paracetamol can be used after dilution in IV dose.
No. Oily paracetamol is for IM injection.
IM injection.
And it.
This is not
Dr.
for IV.
Venugopal Urs from Mysore asked whether clonazepam can be used as prophylaxis for febrile seizures.
Debatable role.
No, it is mentioned in the recent edition of Nelson.
Okay. Then Dr. Vijay Kumar.
Nelson mentions clonazepam 8th hourly instead of our clobazam as one of the options for prevention of sleep. The latest edition, Nelson mentions that. Clonazepam, oral.
Then Dr. Vijay Kumar Chennai says that nimesulide is banned by US FDA, but why is it still available in India? Not available as syrup. Not available as syrup, but tablets are available.
Tablets are available, not syrup.
Okay, so that brings us to the end of all the questions. So I think let's do one thing. Let's have the last round of messages from our panelists. So let's start with Dr. Sarah. What message would you like to give? One message to the audience.
Don't treat fever, but treat the discomfort of the child.
Thank you. Dr. Surendranath.
If you want to treat with the proper dose of 15 mg per kg per dose.
Dr. Rashna.
I think I'd like to tell the parents and everyone that fever is your friend, not your foe, because it's actually indicating that something is happening to your child. So treat it with the proper advice and don't overdo things.
Dr. Abhay.
Fever is not an antibiotic deficiency syndrome.
Oh, thank you. Nice. Okay. So now we'll have Dr. Balasubramaniam for his two comments as moderator.
One comment. Fever is only a symptom which does not kill by itself. Don't panic. Don't go by the numbers, go by the child's activity. 2, the best and the safest drug for treatment of fever, if you want to treat not the numbers, but the child's distress, it is paracetamol. Thank you.
Thank you, sir. Thank you very much. I think Dr. Anand Vasudev, quickly, one comment from you.
Yeah, I think I just want to say it was an excellent discussion and a lot of things revealed and new things to be learned. I think it was excellent.
Thank you. So I think in conclusion, my last word will be thank you for all the knowledge we gained today from all the panelists and from, of course, from Dr. Balasubramaniam. So I hand it back to Dr. Manjula and to Krishna Kumar to take it forward.
Unmute.
Unmute, Dr. Manjula.
Sorry. Thank you very much. It was really wonderful discussion and very insightful. I'm sure all the participants enjoyed it as much as we enjoyed listening to it. I hand it over to Mr. Girish, Vice President of Microlabs, to give the vote of thanks. Over to you, Mr. Girish.
Yeah, it's almost like 10:30. So I would like to take a moment on behalf of Microlabs, Microknowledge Academy, and Fever Foundation on this scientific initiative. In fact, the concept of Fever Week itself has been originated from the advisory board of Fever Foundation. And this panel has been providing insightful presentations, excellent debates, and the knowledge sharing to all of you. So I extend my gratitude to my chief guest, Dr. Basuraj, IIP President, and also all the eminent moderators, the panelists of their invaluable contributions for this event. More importantly, all of you who have been attended the scientific event, spark with the new information, which I feel that it will help you to propel in your day-to-day practices, right? I convey my regards to my internal team, held by Dr. Manjula from medical department, sales and marketing team, digital partners for their involvement in the organizing this particular event. And we at Microlabs assured many scientific events in future too. This is just the beginning for us for this year. And I believe that the panelists will be with us for conducting some more meaningful events in the future too. So thank you one and all, and have a great evening.
Thank you. Namaste.
Thank you.
Good night, sir.
Bye.
Thank you, everybody, sir. Good
Thank you,
night.
Dr. Bala,
Thank you
Dr.
so
Jagdish.
much.
Thank you so much.
Good night.
Thank you, sir.
Good night.
Thank you.